This first test is going to look at the ability for the right ankle to fold during knee tracking. And you'll notice that there's quite a bit of valgusing occurring with that toe out position. This second test is going to look at the ability for the foot to pronate and supinate. And as you notice on that right side, as he rotates to the left, there's a lack of pronation and dropping of that midfoot. And this test, I'm just checking to see the ability for the tibia and the fibula to fold, the talus to fold, and the midfoot to splay. Noticing that there's a significant block for the ability to fold on the tibia and on the talus. This test, I'm looking at weight bearing and transfer of weight through the forefoot. And he's having a hard time getting weight into his big toe here. A lot of weight on the lateral column of the foot. And on this test, it's the same thing, just looking at through the back of the foot. Should be symmetrical weight bearing throughout knee tracking. This test, we're just looking at the ability for the great toe to extend and comparing it against the left side. So now we're looking at a single leg balance. Notice how there's a lot of challenge with keeping that big toe down to stabilize the foot. Also, quite a bit of challenge with the transverse plane stability and frontal plane stability here. So let's check some dynamic balance as well. Notice as how he's reaching, there's a lot of knee valgus or collapse inwards. As he reaches, a lot of that's coming from a lack of stability at the foot. So now I'm checking passive range of motion with contacts on the lateral and medial aspects of the forefoot, just to trace and isolate where there might be restrictions in the myofascial structures of the back of the lower leg and foot. Noticing there's a hard time to evert the foot, that subtalar joint having a hard time going into eversion, and there's a lot of restrictions in that Achilles trying to separate away from the back of the tibia. So as I do some tracing and isolating through the back of the fibula, checking through the superficial fascia and skin layer, and noticing a restriction inwards towards the Achilles. So I'm going to use some soft tissue mobilization techniques to try to improve the mobility at that structure. Here I'm using some muscle bending and some perpendicular deformation techniques from Functional Mobilization 1 coursework. And now I'm going to be using some DISOM to improve the circumferential mobility of those structures. And I'm asking the patient to do some active range of motion at the ankle, which will help to free up those restrictions quite a bit faster. So I'm going to be using a little bit of cupping as I do some long passes through the skin and superficial fascia, the outer layers of that myofascial compartment, looking for any areas that are having a hard time distracting away. And I'm going to be placing 2 cups over the interface between the gastroc, soleus, and the musculotendinous junction. And the cups are going to help improve the ability for those fascial layers to slide and glide while the patient does some active range of motion at the knee and ankle through a variety of directions and planes. Now I'm going to put a couple cups on the front outer compartment of the shin. And this is just going to help improve the ability for those structures to slide and glide while the patient does some active range of motion knee tracking in this weight-bearing position. And here I'm just guiding the patient's knee over the center of the foot, improving a little bit of motor control. Now I'm working on improving the ability for that heel bone to distract away from the talus bone while the patient is in this end range dorsiflexion of the ankle. He's got a strap to help maintain the position, and he's doing some active range of motion hip hiking and trying to push down into that strap. And now I'm going to be improving the ability for that talus bone to distract away from the tibia. As range of motion improves and the ability for those structures to distract increases, I'll take up the slack and continue until there's a springy end feel. And on this one, I'm also directing my force a little bit more towards the inside part of the talus, which is where the most restricted direction was. So now we're in this hook lying position, and I'm going to be working on the ability for that tibia to move posterior, and that's going to help with the ability to bend the ankle. I'm asking my patient to do some rotations through the hip as I mobilize that, and some bridges, as well as trying to push the foot down into that foam roll. These are all active participation from the patient while I maintain my sustained pressure on that restriction. And these are all just functional mobilizations. Now I'm guiding that knee a little bit more central and also lateral, as that was the direction of the hardest end feel. So now I'm feeling for that most restricted part on the talus, getting right on it and creating a force vector in the direction of the hardest end feel while the patient repeats all those same active movements with bridges, active pushing down into the foam roller. And I take up the slack as the restrictions start to improve. And here I'm just using a broader contact, which can be more comfortable sometimes. Now we've got some space in that ability for the heel to distract. Now we're going to work on some shearing techniques and rotation techniques of that heel bone. And this is in a side lying position. First, I'm just identifying where that area on the heel bone is having the hardest time moving, and I create sustained pressure right into the end feel. And my patient is doing active pushing down into my leg and the strap, and also actively rotating his foot upwards. So now I'm just checking through the bottom of the foot through any other soft tissue restrictions, and checking along the medial side of that great toe tendon there, and through the plantar fascia, using a fascia-free tool just to help improve the ability of that tissue to mobilize. And putting my patient in a mid-range position here, doing some active range of motion through the toes and foot. And I'm just keeping sustained pressure on that restriction. And now I'm creating some space by trying to move the toes, the toe tendons laterally while my patient goes through active range of motion as I try to find the hardest end feel there. As these soft tissue restrictions start to improve, I'm going to work a little bit deeper now and work at the great toe's ability to extend on the midfoot. So as I localize and trace to find the hardest end feel, I'm going to block right there and ask the patient to push down into my hand. And as that structure starts to ease, I take up the slack. As you gain range of motion through soft tissue work and functional mobilizations, it's important to re-educate the neuromuscular system. And for that, we use PNF techniques, proprioceptive neuromuscular facilitation. For this one, I'm using a prolonged hold to engage the foot and asking the patient to slowly let me move them, working on the ability to control that range of motion. And now working on the same technique, just in a downwards position through the bottom of the foot and the back of the leg, and trying to get that all to integrate into their trunk. So now I'm going to start challenging more of the lower extremity here in a sideline position, trying to re-educate the neuromuscular system here to hold this position in a little bit more challenging position, and still working on these ankle pivots, which is challenging to be able to move the ankle in isolation. And eventually we'll start to layer that into a full pattern through the hip, knee, and ankle. Checking our work here, you'll notice right away that that right ankle is moving a lot more symmetrically. Better ability to fold, better mobility through the ankle, all the way down from the leg in both directions. And access to stability here is also greatly improved after working on some mobility work and neuromuscular re-education and motor control training. Dynamic balance is also greatly improved here. That great toe usage has also been enhanced quite a bit. And valgus is also improved at the knee. So now we're going to be working on some strengthening and stability work through the ankle. And these are going to be upside down BOSU clocks. And I'm asking my patient to point his toes forwards towards 12 o'clock, backwards towards 6 o'clock, and side to side at 3 and 9 o'clock. And when they're at a challenging position, they'll spend more time there for their home program. Now we're working on the ability to maintain balance and engage some endurance muscles of the foot and arch. This dowel is there for assistance as needed. And we'll typically progress into an active reach while standing on the upside down BOSU. And that dowel is still there for assistance as needed. This really works a lot of endurance into the foot and the hip. Now we're working on some plyometric techniques to improve elasticity of those tendons and myofascial structures of the lower leg using the shuttle press. And now we're going to work a little bit of stability work against the wall and a forward lean. And I'm creating a contact behind the back of the upper tibia so the patient has a cue to engage the quadricep and the soleus, as well as engaging that right big toe. My other contact's up at his left pelvis to engage the trunk. Once these areas are stable, I'm asking the patient to do some repeated heel raises, and I'm monitoring the quality of the range of motion here. Initially, they're starting out on the outer aspect or the pinky toe side, and I'm giving cues to maintain a little bit more weight bearing through that inside column of the foot and great toe, which is really tough for this patient. On these, I'm working some more PNF techniques with contacts at the lateral pelvis, while this patient is working on lateral movements, initiating from their foot and using their whole body to strengthen up the foot. And now we're going to use a sled push, putting it all together in a functional task here. A lot of demand through the trunk and legs and foot. We use a lot of blood flow restriction in our clinic, and this is one way to create a lot of muscular strength with a low weight in the lower leg.